A strong, robust, and trusted public health system is one that has the resources, the tools, and the authorities to be able to promote and protect the public's health. It's a public health system that you then see able to reduce rates of chronic disease, to be able to address infectious disease outbreaks rapidly and effectively. It's one that's able to detect threats such as environmental risks, helps to promote maternal and child and family health, and it's one that is trusted to be able to provide effective communications to communities to know how to promote and protect their health. Since 2008, Trust for America's Health has been issuing a blueprint report every 4 years to inform the incoming administration and Congress about key national public health priorities to be able to promote and protect the nation's health. So it's vitally important that we provide this blueprint for the incoming administration and Congress, because regardless of the outcomes of the election, public health will be key.
Public health has been systematically underfunded for decades.
When we are speaking with members of Congress about what's important to local governmental public health, we often talk about the need for investment in infrastructure and in workforce. Infrastructure means the things that allow our local health departments to get work done every day. The buildings that they use, the equipment that they use, the data that they exchange and use to help inform their decisions, everything that helps them to operate on a day-to-day basis.
One of the challenges that local and state health departments have is that their funding is in small, discrete cycles that doesn't allow long-term planning and it doesn't allow strategic investments. I want health departments to be able to look at the horizon and say, this is a threat that's coming. I need to invest resources now to do that. In order to make that possible, the funding has to be predictable and sustainable.
There is nothing partisan about protecting the public's health. Health emergencies happen in every community, in every state, whether it's a red state or a blue state. And it's important that we have the systems in place to be able to protect and promote health, especially in times of crisis.
A lot of departments, unfortunately, have antiquated systems that need investment. There's no reason why we should be faxing. I think the biggest opportunity we have is in modernizing our data systems to be brought up to the times, to be integrated both within their department, with exterior partners like hospital and healthcare systems, and with the CDC and other agencies.
Federal investments in our local public health departments, in our public health system in general, are critical to allowing us to be able to do the work on the ground to prevent illness in communities, to keep them safe, to address outbreaks, and also to address the continuing threats that our communities face every day. Local health departments are on the front lines of public health in their community. They are working day in and day out to ensure that community safety and wellness. They are the community health strategists for their jurisdictions across the country.
The thing that's unique about public health is that the return on that investment is enormous. And healthy communities are economically viable communities.
The next administration has a unique opportunity to strengthen our public health system by investing in prevention in our country, by really focusing on what it takes to keep people healthy and well.
Good afternoon. Thank you. I'm Dr. Nadine Gracia, President and CEO of Trust for America's Health, commonly known as TFAH. And on behalf of our entire staff, our board of directors, I am so excited and so pleased to welcome you to the release of TFAH's new report, Pathway to a Healthier America, a blueprint for strengthening public health for the next administration and Congress. We are so honored that so many of you could be here with us today in person, and there are many who are joining us via the live stream. Now, for those of you who are just being introduced to our organization, TFAH is a nonprofit, nonpartisan public health policy, research, and advocacy organization. We're committed to promoting optimal health for every person and community and making the prevention of illness and injury a national priority. Now, this is, as you heard in the video, TFAH's 5th edition of our Blueprint Report, which we release every 4 years. It's intended to provide a roadmap for the administration and Congress that will be coming into office in January of 2025 so that we can improve the health and well-being of our nation, so that we can strengthen the nation's public health system at all levels, and to protect our nation's health and economic security. Now, since our first blueprint report in 2008, we found that these documents serve not only as a source of policy inspiration and action for lawmakers and administration officials, but it's also a rallying point for advocates from a variety of fields who find agreement among the recommendations. Now, I'm sure it's no surprise to you when I say that this year's report could not come at a more uncertain, and more urgent moment for public health. Public health is at an inflection point. Yet when Congress and the administration act in support of public health, we know we can improve the nation's health. Since TFAH's last blueprint report in 2020, we've noted some important advancements in public health policies and programs, and I'm just going to highlight a few examples of those accomplishments. The release of the first public health infrastructure grants to shore up long-neglected foundations of governmental public health systems across the country. The COVID-19 vaccination campaign, which prevented millions of deaths and saved more than $1 trillion in healthcare spending in the US alone. The launch of the 988 Suicide and Crisis Lifeline to help people who are experiencing mental health-related distress, or if someone is worried about a loved one who may need crisis support. The expansion of Medicare coverage of vaccines at no cost to patients. Major steps that we're making in modernizing our public health data systems thanks to investments from Congress, and the strengthening of nutrition programs like Healthy School Meals and the Women, Infants, and Children, or WIC program, which are important to ending hunger and promoting access to healthy food. But on the other side of this coin comes the great challenges for and the threats to public health. Threats such as the precipitous spread of misinformation and disinformation that are really leading to real-world consequences like outbreaks of vaccine-preventable diseases. Congress rescinding billions of dollars that were intended to strengthen public health workforce and capabilities. Proposals to fundamentally restructure federal public health agencies, limiting what diseases and conditions that they can respond to. Harassment of public health officials and the chronic understaffing of the public health workforce. Instances of political interference with federal health agency actions, which can contribute to the public's mistrust of these agencies. And policy and court decisions that could place dangerous limits on public health authorities at all levels. These opportunities and these challenges all happening now, they truly make the blueprint all the more pressing. Our report is a vision specifically for public health and prevention, and bolstering the public health system to meet the growing challenges of the 21st century. Making sure our nation is safe and healthy is not the purview of any single agency, and that's why the blueprint recommendations cross 6 priority areas that, taken together, will help to promote health and well-being across the lifespan, protect national security, and support economic stability. Now, you may be noticing that we are gathering here today in advance of the 2024 elections. Regardless of the outcome of the elections, our roadmap for the next administration and Congress comes down to principles that we can and should all agree on. That all children deserve the opportunity to grow up to be as healthy as possible. That we all desire the opportunity to age with dignity in healthy and supportive environments. And that all communities should have the same level of protection from new health threats and the opportunity to thrive. Now, you're hearing that the blueprint report is intended for policymakers, for the administration and Congress. But let me challenge us that each of us has a role to play in promoting the public's health, in championing a strong public health system. And your presence here today, whether you're here in the room or you're joining us online, it demonstrates that you care and that you're concerned about the health, well-being, safety, and security of communities and our nation as a whole. I'm looking forward to us having this conversation together this afternoon. Now, our program today is going to help illuminate some of these critical issues, and we're going to begin with an overview of the blueprint report, and then we'll have 2 panel conversations featuring truly an incredible lineup of speakers for an engaging discussion on the path forward. And I promise there will be an opportunity for the audience to ask questions during the panel sessions. So are you ready for our conversation this afternoon? Yes. All right. It's my pleasure to introduce my colleague, Dr. Takesha Dewan Everett, the Executive Vice President of Trust for America's Health, who is going to present a high-level overview and key points from the blueprint. Dr. Everett?
Good afternoon, and thank you so much, Nadine, for that introduction. It is my honor to share with you some key aspects of our blueprint report that we've worked on for a number of months, days, years, tirelessly with a lot of you who are in this room, who are watching on the live stream and across the nation. This report was developed with input from our staff, our board of directors, as well as through convening and consulting with a number of public health leaders, academicians, civil rights organizations, community-based organizations, and community members. Through a process of socializing specific themes, listening to your ideas, and researching evidence-based solutions, we developed the 2024 Blueprint Report as a proactive perspective of what the 119th Congress and incoming administration should address to advance the public health system and our nation's health. This report has been endorsed by 14 organizations, each of whom were among those who participated in our convening process. Now, this group list is not exhaustive, but it definitely represents a cross-section of groups who believe that population health and the health and resilience of our public health system must be a national priority. We want to acknowledge them now and thank them for their support of their work on this report and throughout our process. The Blueprint Report, as Nadine mentioned, is structured across six key themes. The report has a number of chapters, each related to those themes, and the narrative in the chapter talks about the background related to that issue. We note the problem at hand, as well as the proposed solutions to address the public health challenges and opportunities before us. Each chapter also highlights the progress and stories of impact, showing that when Congress and the administration act to put the public health system first, we know that great strides can be made toward advancing population health. The chapters go on to note evidence-based solutions necessary to move our nation's health and well-being forward. Now, today I'm going to walk through the priorities and highlight just a few of the recommendations. We want to make sure that we get into the conversation, so rest assured what I'm highlighting today are just a few of the recommendations in the report. For a more detailed view of each theme, I encourage you to read the report in full, which can be found on our website at TFAH.org. That's T as in trust, F as in for, A as in Americas, H, health.org. Our first priority focuses on the important need to invest in infrastructure and workforce to ensure our public health system can meet the challenges and opportunities of the 21st century. Insufficient, inconsistent, siloed funding, and chronic underinvestment in public health have limited the public health system's ability to modernize basic public health infrastructure, provide essential services, and adapt to the new and evolving health risks, putting our nation's health and economy at risk. Policymakers have been able to when policymakers provide consistent cross-cutting funding to support the foundations of a strong 21st century public health system, we know that this will improve our infrastructure, it'll give us a larger, more diverse, and better equipped workforce, and ultimately modernize our data systems. To achieve this, the Blueprint Report offers several recommendations. Among them, promoting and increasing the overall funding for CDC to strengthen public health and save lives nationwide. Ensuring continuous improvement of public health infrastructure, investing in public health data modernization, and enacting the Improving Data in Public Health Act to better detect and contain health threats, and supporting efforts to bolster recruitment, retention, and resilience of the public health workforce. Our second priority is strengthen prevention, readiness, and response to health security threats. Here, we're thinking about the fact that public health hazards such as infectious disease, outbreaks, disasters, and bioterrorism are increasing, and they pose significant threats to our nation's security, well-being, and prosperity. Too often, federal responses for health emergencies are hampered by inadequate funding and challenges to public health authorities. The nation's high rates of chronic disease and underlying health and socioeconomic disparities create additional vulnerabilities. Our nation needs to redouble its efforts to prepare for and respond to the public health emergencies wherever they originate. We must build on recent progress and heed the lessons from the COVID-19 pandemic to protect the health of all Americans. To prevent, address, and respond to the health security threats we face in our nation, the White House should maintain coordination and leadership around public health emergencies and biodefense. Congress should expand public health emergency preparedness, funding for state, tribal, local, and territorial jurisdictions, as well as enact legislation to ensure access to vaccines for uninsured and underinsured individuals. Finally, the White House and Congress should renew the nation's global health security commitment. Moving to our third priority, because there are 6, so we're going to move quite rapidly going through all of them. The third priority is to promote the health and well-being of individuals, families, and communities across the lifespan. Increased life expectancy is one of the greatest public health advances we've seen in our country and across the world. And while there is vast variability in the life expectancy along racial, ethnicity, socioeconomic status, and geography, there was also a slight decrease in decline in our life expectancy in 2020 and 2021. It still remains true that people are living longer in the US than they were in the year 1900. And that's largely due to public health innovations and interventions. Yet in our country, the vast majority of the $4.5 trillion we spend on health is devoted to the treatment of illness and injury rather than prevention and public health. Promoting good health across the lifespan requires leveraging public health resources and expertise and improving coordination between and among public health, healthcare, social services, and other sectors. Government at all levels need to engage community-based individuals and leaders and ensure that our funding and tailoring our programs are aimed at reducing health risk factors among all age groups. Focusing our efforts on those populations that are disproportionately experiencing barriers to optimal health is an additional key improvement to our nation's health that is necessary and needed. A deep investment in promoting the health and well-being of individuals, families, and communities across the lifespan requires a commitment from Congress and the incoming administration that includes increased funding for CDC's National Center for Chronic Disease Prevention and Health Promotion, enhanced and protected access to the Supplemental Nutritional Assistance Program. We need to make healthy school meals for all permanent. We need to pass the Preventing Adverse Childhood Experiences Act and increase the investment in CDC's ACEs program. We need to support SAMHSA's efforts to bolster the continuum of crisis care and fund CDC's comprehensive suicide prevention program. And lastly, we need to strengthen CDC's healthy aging efforts and support and sustain age-friendly public health systems in local, state, tribal, and territorial public health departments. Our fourth priority in our report is centered on advancing health equity by addressing structural discrimination. Structural discrimination and the resultant systemic inequities have been perpetuated through policies, norms, and practices in the United States for hundreds of years. Because of the long-standing and ongoing inequities, disparities in health have been persistent. We've seen increased risk of poor health and higher rates of deaths from preventable illness and injury among populations who have been disadvantaged. Achieving health equity requires an intentional focus, one that is focused on ending structural discrimination and making specific actions toward driving systemic change. Now, given the social, economic, and systemic factors that drive inequity, our response must be universal. We need a multi-agency, multi-sector, and coordinated response to eradicate health inequities and disparities. This requires concerted leadership. The incoming administration and Congress needs to make sure that we are addressing the allocation of resources and transform our policies in a way that advances equity. Now, I want to point out that several of our recommendations in this chapter and in other themes are centered around data. Let's be clear. Data shows us that the evidence supports the fact that we need to increase our focus on data because there are populations that are masked when we don't collect our data correctly. We know that disparities exist for those populations, but we can't fully grasp them because we have outdated data collection processes and systems. But it's important to note, while data is necessary, it alone is not sufficient. The incoming Congress and administration must have a focus on equity that includes regularly updating and reporting on the progress of equity action plans across all of the agencies that is inclusive of but extends beyond tracking disparities. We need to ensure that we have accurate and complete data collection that is able to report health information along a number of lines, including race, ethnicity, age, sex, disability, language, sexual orientation, gender identity, and geography. We also need to do what's right as a nation and respect and honor the sovereignty of tribal nations by rectifying the funding shortfalls that have woefully been going on for far too long and that are found as a result of Executive Order 14112 that allows for tribal self-determination and the promotion of trust in our tribal nations. Our fifth priority, I'm nearing the end, you all, so you get to what you're all here and waiting for. Our fifth priority is about addressing non-medical drivers of health. Now, there's growing recognition that non-medical factors are significant contributors to our nation's poor health outcomes, and yet our policies have not caught up with that. Our actions and our investments aren't necessarily in the place that help us address those non-medical factors. The nation's health and economic security depends on us moving further upstream to address those issues and reduce health disparities. The public health sector must be intentionally incorporated into the planning and execution of health-related activities and initiatives and better align those disparate systems to approach population health. We also must make sure that community members are full partners and that policies extend to alleviating poverty. Some ideas and recommendations in our report include increased funding to $150 million annually for the Social Determinants of Health program at CDC and pass the Improving Social Determinants of Health Act. We need to continue to build on CMS's ability to support Medicaid, Medicare, and CHIP program coverage to address the health-related social needs of patients in their programs. And lastly, we need to amend our tax laws to increase economic opportunity for families by expanding the child tax credit and the earned income tax credit. Our sixth and final priority theme, which is very new for us having it in this report, centers on enhancing and protecting the scientific integrity, effectiveness, and accountability of the agencies charged with protecting the health of all Americans. Chronic underfunding, and as Nadine mentioned, the misinformation and disinformation that is rapidly spreading in our society, workforce shortages, threats to the public health infrastructure and authority, as well as the erosion of trust in our nation's public health agencies, are putting decades of progress at risk. It's putting the safety of our nation at risk. The next Congress and administration must ensure that the federal, state, local, tribal, and territorial agencies can do their job, making sure that our public health ecosystem have the necessary resources, the infrastructure, trust, and authorities that are needed to fulfill their mission. To achieve this, we must first maintain the existing structure of our federal health agencies, each of which have specific roles and specific expertise in protecting the nation's health. We must also protect the scientific integrity of our leaders and the public health agencies, allowing them again to do their job. We need to invest and prioritize in effective public health communications and reduce the spread of misinformation and disinformation. And we must reject laws that weaken the preemption, I can't say it today, weaken or preempt public health authorities, which could threaten such basic public health protections as outbreak detections, vaccinations, and emergency response. This is just an overview of the recommendations in our blueprint. Again, I encourage you to take an opportunity to read the blueprint thoroughly. We've produced this through a thoughtful process, and we know that if we collectively work together towards accomplishing the recommendations in our report, we can advance the health and well-being of our nation and push forward through the unknown, known, and unforeseen challenges and opportunities of tomorrow. I thank you so much for your attention and your time, and I now welcome Dr. Gracia back to the stage to lead us through the rest of our amazing program this afternoon.
Thank you, Takesha, for that great overview. It is wonderful to see all of the important work that's been done and many of our partners who are here who are engaged in this process. So we are ready now to dive into our conversations, the first of our two panels, which we are calling the Path Forward, for our nation's health and health security. And we really have a fantastic panel here for you. Joining me here on stage is the 21st Secretary of Health and Human Services, Kathleen Sebelius. Secretary Sebelius has been engaged in health policy for decades in the public and private sectors. She served in President Obama's cabinet and as HHS Secretary and was elected statewide 4 times as Governor and Insurance Commissioner in Kansas. Currently, Secretary Sebelius is the CEO of Sebelius Resources, LLC. She serves on several corporate boards and continues engaging in policy work with KFF and co-leads the health strategy group of the Aspen Institute. Welcome, Secretary Sebelius. It's so wonderful to have you here with us.
Thank you.
Thank you.
And joining us virtually, yes, technology working for us today. Joining us virtually is the 20th Secretary of Health and Human Services, Michael Leavitt. Secretary Leavitt was elected as governor of Utah for 3 terms and served in 2 roles in the cabinet of President George W. Bush, first as administrator of the United States Environmental Protection Agency, and then as the Secretary of Health and Human Services. After leaving public service, Secretary Leavitt founded Leavitt Partners and has focused on the advancement of value-based healthcare. And he's active as well in corporate governance and currently serves as the chairman of Intermountain Health. Welcome, Secretary Leavitt. Honored to have you joining us as well today.
Thank you. And, good afternoon to all of you, and a special hello to my friend Kathleen Sebelius.
Well, this is really a special opportunity because not only are Secretary Sebelius and Secretary Leavitt former HHS secretaries, as you heard in their bios, they're both former governors. And I just actually learned outside the room when I was speaking with Secretary Sebelius that they were governors at the same time. So really have important perspectives on these issues that we're going to be addressing about strengthening public health and prevention at all levels when we think about this federally, globally, as well as at the state and local level. So we're going to jump right into our conversation with these 2 incredible individuals. Secretaries, you know, there are a multitude of public health crises that are happening as we speak. We're still recovering from Hurricane Helene, preparing for Hurricane Milton, measles outbreaks, rising rates of chronic diseases, the mental health and substance use crisis. Let's talk about priorities and priority setting. What do you see as some of the most important opportunities that the next HHS secretary should be prioritizing when they're coming into their term to improve the health of all Americans? And Secretary Sebelius, we'll start with you.
Well, thank you, Nadine. I want to deviate for a minute. Mike, it's great to see you. I'm sorry it's virtual, but it's nice to see you. And I had the great pleasure of working with Nadine at HHS. She was a trusted colleague and ally, so it's also lovely to see your great ongoing work. I'm fully immersed in public health today because yesterday I got my updated COVID shot and my flu vaccine, so I'm sore on both sides. And we had a medical emergency on the plane this morning as I was coming in, and I watched not only the flight attendants, but an amazing young doctor leap into action. And it was an example of why we all, in an emergency, think public health is a really great idea. Unfortunately, we don't do that day in and day out. So I'd start by just saying, I think your blueprint and the priorities in TFAH's analysis are right on target. I will tell you, as a governor, there is no constituency for public health. There may not be as strong a constituency as is needed in Washington, but at the state level, there is no group that shows up on a regular basis and advocates for money in public health. And those of us who serve in office who are interested in that, I mean, you can tuck money in emergency purposes, you can tuck money elsewhere, but it's a real, I think, brings home the fact that the federal government has to lead in public health, has to drive money to the states, has to, you know, in some ways, I'm a believer, even though I'm a states' rights person, in command and control once an emergency hits, particularly across the country, because states just don't have the resources, don't have the expertise. So whether it's data collection or access to materials or a public health message that needs to be clear and effective across the country, I think the federal government in this instance should lead. And I'm struck, Nadine, by, we're up to now watching Milton barrel toward Tampa and surrounding areas. The language and the preparation and the issues around natural disasters could as easily be public health. We know the communities that are going to be most vulnerable don't have access to transportation, don't have access to food, or have spotty communications, same with health. We know that there's a disparate way to respond. We know some people will listen to the information and some won't. I think for the first time we're seeing misinformation about natural disasters being promoted in airwaves and networks. But I think that Congress would be really wise to first look very honestly at what we learned from COVID, what we did right and what we did wrong, because I think that is a recent experience in public health that we should all learn from. And secondly, really look at the natural disasters, because they somehow, if you move it a little bit away from health, I think people may be able to more objectively look at who are the vulnerable communities, how we drive money to them, who responds, how the federal government interacts with state and local areas, what kind of data is collected, what kind of information is used. And it's an all hands on deck moment. Public health, we are at a crisis point, I think, and we would be wise to see it as a natural disaster that's about to hit us.
That's powerful. Public health being at a crisis moment and the analogy to emergency response.
You bet.
Secretary Leavitt, your perspective on this.
I would hope that there could be two messages delivered, not just to the new government, but also to the American people across the board. The first is just a dichotomy. While we have a need for federal funding of public health, we should never forget that the workforce we're talking about, the public health infrastructure we're talking about, are state and local health workers, not federal workers. When both Kathleen and I were Secretary of Health, somewhere between 80,000 and 100,000 people were employed, but very few of them as caregivers and emergency providers. Those are in the state and local governments. And the message there is we can't let the state and local governments off the hook here. That is to say, they have responsibility. This is a fundamental local responsibility. And if we just depend on federal funding, then we're going to be funding it in a spotty way that's targeted on certain things, but lacks the capacity for local governments to respond. So part of this effort is to just remind the state and the local governments, this is your duty. And we can't be diverting monies away from public health just because we think the federal government might step in. The second thing I will point out is just how crucial public health is to the health economics of our country, which is now more than just health economics. It is our national economic policy. We now spend nearly twice the amount per of our GDP on healthcare than any of our economic competitors. And the way we have made historic progress isn't by twisting the knobs on our healthcare system. It's in public health. When I headed the Environmental Protection Agency, I became very aware that it was not just a regulatory agency, it was a public health agency. And that vast portions of the assistance and progress that we've made in longevity, for example, have come from cleaning the air, from cleaning the water, from creating an environment that in fact does support health. So those two messages, the states have a duty, local governments have a duty as well, remembering that that's how progress is made, is through public health.
Secretary Leavitt, if I could continue on that vein that you were speaking about with regards to that investment in public health and at the federal, but also at the state and local level. Here we are sitting in 2024 and we're acknowledging how important public health is, and yet that investment is still not being made. There's still policy debates happening about investing and sustaining that investment in public health. From your vantage point, how do you see this translating into issues that can help the long-term health of the nation, and how do we convince our policymakers to maintain that attention to these issues in terms of prevention and public health, not only in times of crisis, but in the non-emergency times as well?
Well, we had a very good opportunity, and candidly, there was a window of time when I think people were starting to get this during the COVID-19 pandemic. And when you looked around and said, who can help here? And it was public health officials who were employed by counties and cities and states. And there was a dearth of expertise that people were desperate to find. Yes, there were federal people who were deployed, but the reality was the response came from local and state governments. And we need to move at times like that to underscore that message. They're just, even with FEMA, for example, that's a different kind of an emergency. But those who respond in emergencies, like we're going to see from Milton and others, those are state people who are deployed from other states. And we just need to continue to make that point clear, not just in Congress, but in state legislatures. I think former Governor Sebelius will share my frustration that public health just wasn't understood well enough that when they fund Medicaid, they think they're providing assistance to health. What they're not acknowledging is that there is, in fact, a deep, direct, constitutional duty to public health that is clearly the state's obligation.
Secretary, do you want to add to that? Yes.
Well, I think that Mike and Governor Leavitt and I, Secretary, whatever. You've got too many titles. Administrator, too. That's what the EPA head is called. So he's got another one thrown in. There's no disagreement that safety and security, I think, is the primary job of any official in government, local, state, federal, protecting the health and well-being of our population. I'm afraid in some ways, and I don't mean to be contrary about this, but we're almost too nice in public health. We describe things in very kind of abstract terms and, talk about mortality and talk about life existence and whatever. We had 1 million people die in COVID, 1 million people. And many of those people were the most vulnerable in the population. That's an outrage in this country, I think. We have disasters that hit and infections that spread. The fact that kids are getting measles again is amoral in a country like this. I think we got to get a little outrage going here, because there is something really wrong with the richest nation on earth, which doesn't prioritize the health and well-being of its citizens. And the data is important, the workers are important, but somehow we have to raise the level of conversation. And Governor Leavitt has referred to the health economics of healthcare. I think it's also a national security issue. I remember as governor, one of the more frightening briefings, and you probably had it too, Governor, was from our National Guard and listening to folks at the Defense Department when I was secretary, who talked about the fact that if we ever had to have a draft again, if we were in the process of having to summon the age-appropriate Americans to go into our armed forces, at least a third of them are not qualified by health condition to serve. Now think about that. We do not have a able-bodied younger generation who can step up and be engaged, involved in defending this country. And that, to me, information like that is probably pretty important to put out into the general stream. Public health, I think, too many people think it's somebody else's health. It's a kind of term that doesn't have real meaning. They know what responding to a disaster looks like. They know what, an after a reaction looks like, but a prevention, I don't think is as clear. And again, there's some wonderful strategies in the TFAH blueprint, but I think our language in some ways needs to be a little more, frankly, dramatic, because we're not making this up. This is about people staying alive. We still have, longevity rates that don't match any of the other nations in our economic strata. That's not a good place to be for us. So we've got to start talking honestly about what the health of America really looks like, not around money, not about, which public programs, but are people healthy or not? And when they're not healthy, what are they not able to do? Not only be good workers, but be good parents, be, good citizens, and how then can that become more of a priority?
I saw some head nods, Secretary, in the audience from when you were speaking about how we speak about public health and pointing, for example, to the more than 1 million lives that were lost in the pandemic and how we are better prepared for this, for a future pandemic. From both of your vantage points, you've been in these kind of difficult conversations, working across the aisle to have these conversations with lawmakers at all levels to be able to prioritize these types of issues. What do you see as potential for this next Congress and administration, but in particular for the next Congress, outlining these issues that you just addressed, where we can have some opportunity for bipartisan work to address the very issues you've been talking about of focusing in on public health?
Well, again, I think going to lessons learned, I really do think we need a real unpacking quickly and very candidly about what really worked well with our response to COVID and what did not work so well, and what we knew and what we didn't know. That's important, to be very candid and honest. Did we keep kids out of school too long? Probably. Did we know that at the time? No. Did we, what were the correct decisions looking back that really helped people, and what could have hampered the health going forward? That conversation, I think Congress is well equipped to do and do it fairly quickly. And then implement some of those lessons. I think also looking at the response to natural disasters. What goes well? What I remember, and Secretary Leavitt probably was experienced with this also, every time we had a natural disaster when I was secretary, the first teams sent in were beyond the emergency response people who unfortunately often brought the morgue, the stand-up morgue and hospital with them, were the mental health folks. Because one of the things that was learned very quickly is well beyond whatever physical health issues there were huge mental health issues and trauma, and it not only hit with the disaster, but it lasted a lot longer. So those kinds of lessons, I think, to implement on a day-to-day life in this country. And is there adequate funding? Are there adequate not only programs and dollars, but the workforce issue, I think, is one of the major crises facing us today. How do we get kids to understand this could be the most exciting, impactful work they could ever be involved in? How do we start that conversation at a very young level, have internships, have, kids who are able to be involved? I mean, you watch children thrilled to go into a fire station and, they visit places. I've never heard of a visit to a public health agency or a description about, what is it that these folks do. But I think we've got to make it interesting and exciting and as impactful as it really is.
Yeah, sounds like we've got some takers of wanting to bring kids into these public health agencies.
Yeah.
Secretary Levitt, your thoughts on where there may be some opportunities for bipartisan work in the Congress to advance public health?
One specific example would be in the use of data technology among the states and with the federal government. There were, during the pandemic, some glaring examples of the inadequacy of our approach. You had 50 states gathering data in 50 different ways. That's a place where the national government has to step up and begin to establish standards. That's critical because you don't have situational awareness. If you don't have good data, you have no way of responding properly. I think the second thing, and an unfortunate thing, is that we began to see the demonization of public health people, and we need to just stop that and find ways to make clear what heroic individuals and what noble missions they were carrying out. And I think finally we do have an opportunity with the ongoing onset, which they've always been there, emergencies that have come up periodic, whether they're weather related or terrorist related or in some other biological. Every time we have one of those, we need to use them as teaching moments to highlight the contribution that public health makes to our general welfare. And could I just underscore what I heard Kathleen say, and that is we're in competition as a country, not just economic competition, but our fitness as a nation to carry out the routines of a healthy, successful nation. A nation that is not healthy is not going to compete economically, militarily, or in any other way with other countries. And we're now seeing the longevity of Americans drop. That's simply unacceptable and should be startling to every American. Seizing on moments like we will undoubtedly have to teach those lessons is an important mechanism.
Both Secretary Sebelius and Levitt have brought up this issue about readiness in terms of military readiness. And for those of you that aren't as familiar with TFAH's work, that is an area that we often address, in particular around our portfolio on obesity and chronic disease prevention, and where we've found a lot of interest with regards to seeing these rising rates, whether it's in terms of obesity or other chronic diseases, and the concerns really about our military readiness in terms of having a workforce, a service force that's ready to be able to respond. I think you're placing this, public health is really part of that national security infrastructure when we
Very
think
much.
about this in particular. Secretary, Sebelius, I want to come back to you because there was something that Secretary Levitt said around data, and you were nodding your head about the quality and comprehensiveness of data. And I know this is something that you're very passionate about from our work together. And it was not only in times of emergencies, although when you were addressing H1N1, that was a challenge because the data systems were not moving at the pace that we needed to really be able to do the type of response that was hoped for. But you also address this in terms of understanding population health more generally, looking at rates of maternal mortality, looking at rates of chronic diseases, understanding other chronic conditions. What's your perspective on where we stand in terms of our data infrastructure, and both from the vantage point when you were secretary, but also as a governor, how strengthening that data infrastructure can help you in terms of decision making. And I'm asking this question in particular because part of the investments that have been made have been around data modernization, but that's also what's at risk, that's what's under threat.
Well, I think, as Mike said, you can't solve a problem unless you can see the problem, and you can't see the problem if you can't count what's going on. And if, again, lesson learned from COVID, not only was the data full of holes, but people were counting different things at different times in different ways. So it was almost impossible to get a clear national picture. And I would agree wholeheartedly when I started by saying there's some areas that the federal government really has to stand up and be involved. I mean, that's one of them, I think, to have a national count. I mean, right now, I think it is still a voluntary issue where a state can choose whether or not to turn in data to CDC. That's terrifying, absolutely terrifying, because then if somebody says, for whatever reason, we don't have the manpower or womanpower, we don't have the interest, we're against your politics, whatever, we're just not going to tell you what's going on. You can't, I think, have a response or a public health system that is that spotty in a country like ours where so many people travel. I do think, we watched huge improvements be made in the Medicaid data system when, along with the passage of the Affordable Care Act, they said you really have to update your enrollment features. You have to make it easier. You have to count people in a certain way. You have a certain way to figure out assets. And I use that as an example where a national program can be put in place. But without that, you really don't know what's happening. So if we're making vaccine, how many people are sick? Where is the sickness happening? With H1N1, as you remember, you could watch it. It was moving across the country from region to region. With COVID, we sort of had a simultaneous national outbreak. But you wouldn't even know that if people aren't turning in data. So I think we're failing at the fundamentals. I still think we do not have a national health data system collecting information in a uniform way, and actually, skilled and trained folks to do that, and then reporting real time, not 2 weeks later, 4 weeks later, 6 weeks later, but some kind of real time reporting so that the response can be timely, effective, and very specific.
And I think you're pointing out, a big challenge with it, which in part too is the fact that these agreements have to be made with each of the states, right? That CDC is having to make these agreements in order to have that type of reporting, and then understanding, as we heard in the video, right, the fact that for some of these health departments, they're still faxing data in because we
probably still
not having the resources to be able to sufficiently modernize for the growing number of health threats, and so really needing to be able to assure we can sustain that.
Well, and I don't mean to dwell on this point overly, but Mike, I don't know about Utah, but Kansas has had I would say, a real step back. So we are one of the states where the legislature decided in response to COVID that they would limit the public health authorities in various places, that they would stop collecting various kinds of data, that they would disallow public health officials. I mean, one of the keys of epidemiology is the track and trace. If you cannot get information, you can't track and trace. That they made it so that it's totally voluntary if somebody reports an outbreak. Those kinds of situations are now part of our law. So God knows what's going to happen next that hits in a state like ours. But we are far less well equipped right now in 2024 than we were in 2020.
And I think you'll see in our blueprint, why we focus so much around data infrastructure. We've seen some important advancements, looking, for example, at electronic case reporting with that modernization effort. You've seen less than 200 healthcare facilities utilizing it to now more than 41,000, with those types of investments. Imagine what we can do if we continue to be able to ensure that there is that automatic exchange between healthcare and public health, and then also
and health records weren't digitalized until starting in 2009. I mean, that's pretty shocking in a country like this, but we're now actually there so we could share information real time.
You both have pointed out to an understanding that, we're talking about population health broadly. Yes, and I'm gonna turn this first to Secretary Levitt, talking about population health broadly, but we know that there are certain communities, certain populations that are disproportionately impacted, not only in emergencies, but when we look at a whole host of health issues. Secretary Levitt, if I can start with you, how do we not just raise the consciousness, but really raise action to understanding that it's vitally important that every community have the same level of protections, that every community has the opportunity to thrive, but yet we're still seeing disparities, whether it's racial and ethnic disparities, disparities in rural communities, disparities that exist among populations that have lower incomes. How do we really continue to raise the importance of this such that it's an understanding that it's not taking from one community versus the other, but it's actually promoting the health which strengthens our nation?
Well, innately, public health is about the health of the community, the entire community, and that we all, a rising tide lifts all boats, and the opposite of that is also true. So again, I think that one of the great responsibilities of public health is to educate. I don't think people are innately desirous that part of a community be underserved. I just don't think they realize it is and the impact that it has on them. I'd also like to say, I think that part of this bringing public health to the forefront is to teach about what is public health. There are lots of epidemics today that we are under focused on. Sleep is an epidemic. The lack of sleep is an epidemic, and it's having profound impact on the lives of Americans and consequently the economics of health. Mental health is not always thought of as a community issue. It is very much a community issue that we need to be focused on. All of these things are part of the public health and are best dealt with in a way. Fitness, obesity has been something we've talked about for a long time, but it's hard to legislate that. It has to be motivating a change of behavior in all of us.
Well, I remember when we were looking at responsiveness to outbreaks, one of the things that New York City did in a way that I don't know that other communities, I mean, this was a while ago, but they had actually mapped situational awareness of individuals who needed oxygen on a daily basis, who was dependent on insulin. And the reason that was important is when power went down, they knew, Nadine, you needed oxygen, but you also lived on the 37th floor of a building and you couldn't get down to get that oxygen. That kind of information, now I know that it sounds a little big brother or big sistery that, that kind of health information would be collected. On the other hand, it's an absolute life-saving piece of information to have, where people live who are vulnerable, how to get resources. You look at, in a natural disaster, pre-positioning water, pre-positioning food, getting healthcare workers on the ground early on. If we did that in health areas, where you knew exactly where to go, where people who need transportation, when a crisis hits, they can't get there. Again, we know a lot from COVID. We know who is on the front lines. We know who are the most vulnerable because, frankly, they bore the biggest cost of sickness and death, ultimately. Heat mapping that in terms of being ready the next time would be extraordinarily valuable, I think. Where are the first responders? Where are bus drivers and workers who have to be out each and every day? Clearly, we learned a lot about nursing homes. We learned a lot about other areas, but I do think the health equity is both about race and gender and issues that, chronic illness that make people more vulnerable, but it also is where the resources and assets are, and what kind of different resources and assets do one community need versus another. That should be part of our public health data collection and part of our ability to respond. That can only be done at the local level. Clearly, you can't do that from some federal perch on high, but having local, it's sort of the neighbor to neighbor thing. In a neighborhood, a lot of people know that Mr. Smith, 3 doors down, uses crutches and won't be able to get out of his house as the guy next door, but they could have a buddy system. That information mapped and spread throughout communities, I think, can be life-saving and important. Social drivers on health to look at where are the food deserts, who doesn't have, I'm thrilled with the public programs beginning to pay for putting an air conditioner in somebody's house so they don't have heat stroke, making sure that there's food in the refrigerator, getting rid of the throw rugs on a floor so MMA doesn't fall for the 3rd time. Those are as important to health and prosperity of individuals as are, massive clinical programs. So moving more in that direction and understanding, who these individuals are that, again, can only come from the local level.
And you're raising, and we're going to turn to audience questions now, but you're raising, Secretary Sebelius in particular, around these non-medical drivers of health. You lifted them up of transportation, housing, and the quality and safety of housing, and understanding how those structural drivers contribute so significantly to the health disparities that we're seeing. It goes beyond personal behavior to understand, do you even have an opportunity to be healthy? Do you live in a healthy community that has the resources and the conditions to promote health? Let's see if we have any questions from our audience. And we've got Darla, who's going to pass the mic around to our audience members. Yes.
Well, first of all, excellent blueprint. So
and if you wouldn't mind introducing yourself, and that would be wonderful.
John Auerbach from ICF. And again, really applaud the blueprint. To the secretaries, I was thinking of how difficult it is now because Congress does seem to be deadlocked and unable to pass an expanded budget or pass legislation. That may change. We hope it will change in the future. But I also know that there are things that secretaries can do and administrations can do that don't require congressional action. Executive orders or administrative policies. I guess I wonder for both of you, if you were advising the next secretary about the things that could be done even without congressional support that might be in line with the recommendation of TFAH, what do any of those come to mind to you?
Make Mike go first.
Well, I think both Secretary Sebelius and I would acknowledge that one of the great tools that a secretary has is the ability to draw attention to things. Yes, there are regulatory levers that you have, but candidly, they're defined in statute, and they're going to be even more tempered now because of the Chevron decision than they might have in the past. The real opportunities are to pick an area and to begin to use not just bully pulpit, but the workforce, the tools available to begin to teach the kinds of things that we're talking about. I think one of the things that I look back on as having been among the most productive things that I did while I was secretary was in the middle of a crisis that we were anticipating that the H5N1 flu might in fact become a pandemic virus, and we held 53 pandemic summits, bringing the entire public health community and the business community, the education community together to talk about the role of public health. When Medicare Part D was rolled out, and we have an enrollment every year to begin to rally communities around what can be done to assure that people have the services that they need. Those are things that a secretary can do that can have a profound impact by bringing people who do chronic disease management together, by bringing people who are involved in mental health together and begin to teach both ethic and the tools and what is available now and how it can be used. Going to states and saying to the state legislators, look, we're partners, but this is your basic responsibility. I'm here to help you, and here's some money we can give you to help you. But this is a duty that those are things that a cabinet member and member of the public health community can do. I think we really do have to become strong advocates to begin to help people understand how important this is to the economic and medical complexion of our entire state, or our entire nation, rather.
You know, I don't disagree with anything that has been said. I do think that one of the efforts that I was involved in that I think was exciting and hopefully meaningful was this notion of health in all agencies. And you'll remember that. They're, you know, an obscure part of the Affordable Care Act in the prevention area talked about the fact that every agency has assets that could lend themselves to making and helping people be healthier. And it shouldn't just be the health department over on the side thinking about this, but everybody should think about it. So it was a all hands on deck. Every agency was charged with coming to the table. HHS was the lead agency, but coming to the table with ideas. And out of that effort came things like smoke-free public housing. Never had happened before. Set-asides when a new road was built for trails, so that when a highway project went in, there was a place that people could bike or walk. All kinds of efforts that people saw, you know, public health advertisements and vaccine promotion on buses that were part of the. So I think, again, it's really important with public health that all the assets of the government, I mean, you and I saw it, Secretary, when there's a specific outbreak that may be coming our way where it's kind of an all hands on deck. But that structure probably lends itself to a everyday, day in and out. Because when the Secretary of Transportation is thinking about what do I have to bring to the table to make people healthier, what is in my portfolio to do this, it was amazing how creative people could be. Everybody had money. Nobody needed a new bill or a new law or a new whatever. It was just charging them, saying this is really part of what you need to be thinking about as you go forward. And it produced some amazing results, and I think some of that is still very much ongoing. So it's both what assets might be in HHS for the new secretary, but what's in all the departments? You know, what are their opportunities to drive healthier opportunities into communities, work with partners, bring people together. We learned very quickly that, you know, while there was a big effort to get some of the chronically homeless individuals into housing projects, folks won't go into housing projects unless they have services and supports, right? They're not going to go to, as they call them, stick houses without people around them. And at the local level, the housing agencies don't have the authority to bring the services to the table, but HHS did. So we would begin to say to people, okay, we're not going to drive this grant down to the local level unless you, at the local level, put together a community collaborative that includes service providers and housing providers and figure out what your joint effort is going to be. Things like that I think create sort of cross-pollination of good ideas could go on a regular basis.
We've got one more question over here. Secretary Leavitt, were you wanting to make a comment here?
I do. I wanted to put a fine point on. I think the questioner asked a very thoughtful question, and I'd like to, though I think both Kathleen and I have responded to, I want to give a specific idea that if I were secretary, and I won't be, but this will surprise you a bit, coming from a former Republican secretary. I feel so strongly of the need to unify data collection. And it's not going to be a regulation that does it, but regulation could play a role. The next secretary could go through and look for ways to condition federal money on state cooperation in developing common data standards for collection. And then they would need to bring the group together and collaboratively work those standards out. You just can't mandate them. You've got to get people together and allow them to come up with standards themselves, but put the force of the federal government behind it to say, look, you want money from us. There's something we need from you. And it's cooperation and collaboration to develop something that's going to be good for all of us. But as it is, we've got all these different standards being used to collect data. The forms don't match up, the data doesn't match up, and that's going to take a combination of a little bit of incentive, positive or negative, and a lot of collaboration, and that problem could be solved in the next 4 years.
Thank you, Secretary Levitt. Yes, Dr. Kane.
Virginia Kane, President of the National Medical Association, and just want to commend both of our governors. Governor Serbilis, you gave Indiana University, I'm a founding member of the Indiana Health Information Exchange, and you gave us a discretionary $20 million to get our information exchange started, so I just wanted to commend you for that. Sorry, Levitt, that you didn't get your chance with us. Okay.
I actually formed to help us.
But when I look at the recommendations from Trust of America, when we're looking at the data, and you had suggested increasing funding for the social determinants of health at $150 million, the United States is the richest, #1 in the country for economy. We've got a $29 trillion budget. $150 million for social determinants, adding that to our data sets where we can map our assets and our resources, because our poverty with our populations, especially for the Black communities, Latino communities, is at least almost 25, 26%. That seems grossly low. I'd like to have your understanding and recommendations how we can combine that. And I have a great example how you could fund, Trust for America, how you could fund all of our large local health departments all at one time for data modernization. But go.
Well, I can start first by saying, traditionally public health is funded, as you know, more in disease-specific categorical funding, and this kind of cross-cutting funding for public health, whether it's infrastructure, but also to address social determinants of health. I mean, Secretary Sebelius was just making the case of how there is health in all policies. There's still debate about that by some in decision-making positions that public health should be in those spaces. And so being able to actually provide the infrastructure for public health to do this work and not say, it's unfunded for you to now engage with every single sector and not have the workforce and capacity to do that. We've seen actually, even from these initial investments to support a social determinants of health program within CDC, having these accelerated grants, that these things can show the return on investment. We need to continue to build on this over time. And yes, there's urgency to it. I mean, when we're looking at this, we're in the midst of these health crises. There's urgency, and it's not public health alone. I think that's also an important message, is to say it's not the public health system alone that will solve these issues, but it's truly working with multi-sector partners to be able to address these issues. But we also have to recognize that there is a role for public health in these issues. And I think that ties to what I would end with Secretary Levitt and Sebelius on, is there is a concern that there are proposals to actually restructure or limit what public health agencies can do. And from your vantage point as former secretaries of HHS, how does that potentially put the public's health at risk? And how do we convey that it's critically important that we have the mission of public health and the structure of these agencies to be able to do the important work of promoting and protecting health?
So I'm a believer you can't do that out of the public health sector, that you need a broad array of partners as I said, to have a general, colonel, whatever, talk about the security side of health, to have police officers describe community security based on mental health issues, to have teachers and parents come at this. This has to be a lot of voices and a lot of understanding that this is not like a sector that can sit over here in a silo. It is all of us every day, how we live our lives, how well we're able to participate in the society. And I think those kind of community partnerships, again, the blueprint has a lot of information about strengthening partnerships, but I think having just public health officials, it always sounds to too many people like, oh, it's just your job, it's your turf, you're just wanting more money to do whatever it is you do. We don't know what you do anyway, and we don't really care. We're going to look over here. It has to be a community outcry. And I think then we have to take a step before that, which is do the kind of education that Mike has talked about. I really don't think most Americans have any sense of how precarious our public health situation is, how jeopardized we are as a country economically and in terms of security, how we compare to nations across the globe, how we have mothers dying giving birth in the United States of America. Outrageous, totally outrageous. So some of this, I think we have to begin to build partnerships, outrage, impetus on the ground, but by giving people real information about what actually is happening.
Secretary Leavitt, anything you want to add?
I'll simply add that we often think of the best response as being more budget, a different regulation or a new statute. There are times when all of those are critical, but what public health, at the heart of public health, has to be extraordinary collaboration and the use of being able to bring people together to solve problems. The questioner asked about public health, or rather health information exchanges. This is a great example where we had essentially said this data problem isn't just among states, it's among people inside states. And so let's form a place where people can come together and collaborate to have information that can be shared. That was formed under one administration. Kathleen and her administration then funded it. We're now almost 15 years since that time, and we're still working on it as a community. But the public health, the secret sauce for public health advancement is skilled collaboration and good leadership that can bring people together as a convener to solve problems. Yes, we need money. Yes, we need regulation. But at the heart of public health is collaboration among players who can solve problems jointly.
Secretary Leavitt, thank you for that message, because I was going to do a rapid response. Final question or statement from each of you. I think that's an excellent one. Secretary Sebelius, what would you like to say in terms of the path forward as we conclude this panel?
I agree.
In a bipartisan
You bet.
fashion. Excellent. Thank you, Secretary Leavitt, for joining us this afternoon. We truly appreciate it. Everyone, thank you for Secretary Sebelius, who will step down from the stage, and we'll transition to our next panel. Thank you, Secretary. Yes. So we're going to just bring up a couple of chairs for panel 2, as we've got 2 more panelists who will be joining us. Many thanks to Caroline for doing that. As the chairs are being brought to the stage, I'll just introduce this second panel, which we're calling Promoting Health and Saving Lives, Supporting Public Health on the Front Lines. And you're going to hear some of the themes that have been brought out by both Secretary Sebelius and Secretary Leavitt into this panel. And I'll briefly state that this panel is going to speak to, from their perspectives, as public health, healthcare, and policy experts, the pressing issues that policymakers really should be considering in this next administration and Congress. So I'll have our panelists join me on the stage, Dr. Frederick Cerise, Dr. Susan Kansagra, and Dr. Anand Parekh, who will join me on the stage. And I will introduce them going from my left. Dr. Cerise is the president and CEO of Parkland Health, which is one of the largest academic and public safety net hospital systems in the country, serving the comprehensive healthcare needs of a largely uninsured population. Dr. Cerise previously served as the Secretary of Louisiana's Department of Health and Hospitals. Next to him is Dr. Susan Kansagra, who is a public health leader, most recently served as the State Health Officer for North Carolina and the Assistant Secretary for Public Health of the North Carolina Department of Health and Human Services. She also has local experience, having served as the Deputy Commissioner of the New York City Health Department. And then our third speaker is Dr. Anand Parekh. Dr. Parekh is the Chief Medical Advisor at the Bipartisan Policy Center, which is commonly known as BPC. Every time I say the word bipartisan, I see head nods and appreciation. So where he provides clinical and public health expertise across the organization on a variety of policy issues, including the future of public health. And prior to joining BPC, he served as the Deputy Assistant Secretary for Health at HHS. So as you can see, we have an amazing group here with experience and expertise at the federal, state, and local levels, private and public sector experience and expertise. So please join me in welcoming our second panel. So I'm going to start our conversation. Certainly I know something that is top of mind is around what we're seeing in terms of the great human toll from Hurricane Helene. And the concern that is arising around yet another hurricane that is coming toward our shores. And as you heard the Secretary speak about this, it's not only the physical health risks, but it's also the trauma that communities are facing, either in terms of lives lost, some families still searching for loved ones, the trauma of losing your home, seeing your neighbors suffering, all of these issues. And we think then too about the public health, the healthcare, and the policy implications around such significant disasters and emergencies that happen, such as Hurricane Helene. Susan, I want to start with you and first say that our thoughts are with you and the residents of North Carolina as they are continuing to deal with the aftermath of Hurricane Helene. You know, we heard the Secretary speak about what emergency response and preparedness looks like. Can you tell us from your vantage point, having just served as the state health officer for that state, how does a state health officer prepare, respond to what's becoming now really a growing number of these types of emergencies?
Yeah. Well, first, let me just thank you for keeping Western North Carolina in your thoughts and in everybody's thoughts. It really is just devastating to see and heart-wrenching to see what is happening. Families picking up the pieces literally and figuratively, really heart-wrenching. But equally as powerful and uplifting has been all of the support that folks across North Carolina and across the country have been giving, and really appreciate that support. So thanks to those first responders that are still on the ground right now, both federal, state, local officials that are there. Appreciate everyone keeping our communities in their thoughts. To your question, you know, I think this is a really important one because I could talk about the dozens of ways that public health right now is supporting operations on the ground response, whether that's shelter operations, preventing communicable disease, whether that's supporting food sanitation, water quality, making sure our first responders have tetanus vaccine. We could talk about all those things that are happening now, but to me, a critical job of public health is what happened in 364 days before that event happened. Because, you know, we call that readiness, we call that preparedness, but really that is response too. And that is response where you might not know what you're responding to yet, but everything you are doing leading up to an event is something that will come to bear and bring to bear on then the things that happen afterwards. And I think most important there is thinking about what are the systems, the processes, and most importantly, the relationships that you are putting in place. You know, the role of public health is oftentimes that convener, and how we think about that in communities. You know, in North Carolina, we're fortunate. We have dozens of local health departments that support each of our counties, and we have the state health department as well. How we work together along with our federal partners and how we build those relationships and how we build relationships on the ground, whether that's with your dialysis centers, your healthcare organizations, your long-term care facilities, your CBOs that might have access to populations that you can't always get to. I think building those relationships and being ready, regardless of what that emergency will be, is really critical. I also think, the systems that we put in place to keep people healthy, they are important before an emergency, and they are especially important after an emergency. And we are fortunate in North Carolina that we passed Medicaid expansion. We have 550,000 people that now have access to health insurance that otherwise wouldn't have, and many of those people are in Western North Carolina. So the fact that we are able to provide that, behavioral health resources, which you talked about, really fortunate our legislature put forward $800 million investment in behavioral health resources, which were needed before, but especially needed afterward. So I think all that work that happens before an emergency is critical as a state health officer, not just what you're doing after a response, which is equally as critical, but both certainly have their role and are equally important in making sure that we are responding in the best way for our communities.
Thanks, Susan. Fred, from your vantage point, you're sitting there, you're leading a healthcare system. How then do you think about the preparation, the response to these types of emergencies?
Well, I've seen the response from health system. I've seen bad responses and I've seen really positive responses. And so it really varies by system. Unfortunately, there's not a great set of standards that says you shall do this when something terribly unexpected happens that we should all be planning for. So after Katrina, I was in the back of a military vehicle with patients on ventilators on the top of a parking garage of a hospital where there was a man with a gun controlling helicopters, and the patients couldn't get on because other healthy people were running on and off. That is the worst. And it speaks to not having those relationships and plans ahead of time. And I've also seen the best where, in the setting of an Ebola threat in Dallas, hospitals working together to identify a separate facility that would house a potential number of patients that didn't materialize. And I saw hospitals working together during COVID to share data, to share plans, to share resources, to level load, so that as a community we work together to be able to optimize resources to take care of patients. So there are standards. They're not the highest standards in terms of being able to operationalize plans. Joint Commission says you've got to have a plan, but it's a paper plan on what will you do with workforce and resources and utilities and things like that. But I think there's more work to be done with how you will operationalize those plans. Can you go a step further with kind of an accreditation process, or can you ensure that you're planning together with the public health department or with your local hospitals? So I think at this stage, it's still variable and based on those relationships and people's ability to come together beforehand and in anticipation. But there's not a strong standard that we're surveyed to and held to, other than that kind of paper standard.
Thank you. Anand, you're looking at this through the lens of policy, and these emergencies are happening with greater frequency and intensity, whether we're talking about weather-related emergencies like extreme heat or the hurricanes or other issues, but also infectious disease outbreaks, et cetera. How do we make policymakers truly understand the importance of what Susan described, the other 364 days, which are so critical to then how you respond and how you recover from these types of emergencies?
Yeah, thanks, Nadine, for that great question. Congratulations to you and TFAH on an excellent blueprint. Great to be with you and Fred and Susan. I think there are a couple of policy issues. The first is the importance of all hazards preparedness. Any public health emergency can now happen any place at any time. Who would have thought that a hurricane could have such a significant inland impact? And I think that matters for local public health in terms of the messaging to the public, in terms of being prepared. I think that matters for the federal response as well. These are multi-state events now. How do you stretch your resources? How do you connect with private sector partners to form those public-private partnerships for the response? I think funding does matter as well, whether Susan, local public health departments, the public health emergency preparedness program, Fred, the hospital preparedness programs. These are really important federal programs that are underinvested and haven't kept up with inflation. We need to make sure that I think, and this is in the blueprint as well, I think we need to make sure that these programs are fully funded. But even beyond that, there are myriad other policy issues, from flood insurance to weather forecasting through AI, through how do you plan for coastal communities, infrastructure resilience. So a lot of this emergency management and public health, I mean, it's all coordinated, it's all connected, and public health has to be right there.
Absolutely. I'm going to stay with you on in particular to then talk about, as you noted, it's important for the response, but then also thinking about how we create these healthier, more resilient communities to be ready to respond to these types of emergencies and disasters. You spend a lot of time thinking about this. How do we talk to an incoming administration really to prioritize prevention and public health? Because we know the numbers, right? Less than 5% of our annual health spending is on prevention and public health, and yet that's so important to us being able to respond effectively to all of these numerous public health issues.
Yeah, so I think, there's a message to an incoming administration, and I think those of you who have been here in Washington, D.C. and been policymakers here, this is a pretty reactive place. We're a reactive town. There are crises every day, small, large, real, manufactured, but there are crises, and a lot of our attention gets focused on those crises. But public health and prevention demands a totally different mindset. You have to be proactive and not reactive. And so I think it's so important, incumbent upon a new administration to really keep this as a top priority. And that's got to be reflected in strategic plans, in president's budgets, OMB budgets. It's got to be reflected in terms of a set of limited metrics to ensure accountability. And then I think Congress also has a responsibility here in Washington, D.C. Next year is going to be a difficult year, particularly given sort of our fiscal environment. But understanding the opportunities Congress has to support public health emergency preparedness, understand public health, even if it's not with dramatic increases in investments, for our federal agencies, budget authorities, data authorities, hiring flexibilities, passing the Pandemic All Hazards Preparedness Act. So there are, I think, a lot of things that can be done here in Washington, but you really have to have a proactive mindset to embrace prevention and public health. Otherwise, every day just becomes sort of, you're reacting to some crisis.
Absolutely, and it's not only, I think Secretary Sebelius uplifted this, it's not only public health to bring voice to this, it's other sectors. I mean, we're in a broader ecosystem, a broader health ecosystem. Fred, with your work as, and being a healthcare system leader, how can, and we're seeing more of this movement in terms of healthcare leaders really stepping up to say, we need to support and promote and champion public health. This is something you do. How can we get more to really step into this space?
Yeah, it can be difficult because it's not, we've got this artificial distinction between healthcare delivery and public health. And I don't know that the expectations are there, that healthcare delivery systems are essentially, they thrive on sickness. You treat illness and you treat the acute, and that's what the economic model is. And so we've got to be more intentional about pointing those systems towards prevention and public health. And I think that there are ways to do it. It would start with just having an understanding of the system. I bet if you polled hospital CEOs, many of them would not know who the local public health director is in their town. And so starting with making those connections is a good start. Planning together. There are expectations in the Affordable Care Act that we all do a community health needs assessment. Doing that planning with the public health agency, because the issues are common. And so doing that planning together is important. Working on things like data reporting, electronic reporting of data, those things you can do together. We've been able to support our local public health get on Epic because oftentimes they're not going to get the attention of those systems, but you can help them to do that. And so I think being intentional about working together, and then from a policy perspective, putting some expectations on the health systems to say, you've got an expectation to do community health needs assessment, do that together. You've got community benefit expectations, invest in the community through these identified needs. And then some of the financing as well. Medicaid waivers, for instance, where you can put some expectations on prevention, screening, those types of, and incentivize those types of behaviors from health systems that don't, again, normally that's not the economic model for big delivery systems, but you can use some of the payment levers to point them in that direction.
So you're pointing in particular to some actual abilities of federal agencies, whether there's movement in terms of Congress, but actually some actions that could be taken as well from federal agency leadership to be able to move these types of incentives, if you will, or requirements forward.
Right.
So, Susan, I think it would be helpful to hear, certainly from you, there are a lot of comments being made about the capabilities and the partnerships and relationships that public health has. But there are threats, and there are also ways in which public health, as we've been all talking about, has been underfunded for decades. Can you talk to us about, what you're seeing as the threats and what are the opportunities? We want to certainly not pose this solely as the threats that public health is facing, but what are the opportunities, whether they're low-hanging fruit or just actions that can be taken that we can move on quickly at the start of a new administration from your vantage point?
Yeah, thanks for that question. So, I will spend 10 seconds talking about the threats because we all know what they are. Trust, erosion of public health authority, mistrust in government in general, we see those things. And now shifting to the opportunity, which to me is, I think we need to talk about all the ways that the American people have already put their trust in public health. Every time you drop off your child at a child care facility, public health was there, making sure that you could pick up your child at the end of the day and that child was in the best possible environment. If you have a loved one in long-term care, public health was there, making sure that infection prevention policies were practiced to the best of that facility's abilities. If you are building a house, public health was there checking the soil to make sure that your septic system did not leak sewage into your front yard. We know if you go to a restaurant, the restaurant staff worked hard with public health to make sure that you did not walk away with a GI illness. And if you gave birth, public health was there making sure that your child did not have a rare congenital illness and giving that child the best chance of life. So those are all the things that public health is already doing. Those are all the ways that people have already put their trust in public health. And I think those are the stories that we need to start lifting up and talking more about. And I think doing that not only helps build trust, but also helps us advocate for then those things that we need. And I want to touch on one thing Anna mentioned around the FEP funding. In North Carolina, I was looking at some of our figures. We get about $15 million a year, which we put to really good use. Our counties get a lot of that funding. When you divide that by 100 counties, that's around $150,000 per county per year. And I think about just the devastation that we are now, of course, seeing and hearing about from just Helene. Hundreds of millions of dollars that a single county will face. $150,000 investment. Hundreds of millions of dollars that we will now need to pour. And not all of that is preventable, but I think some of that could be if we relook at the equation of what we are investing up front. So, I think those are some of the opportunities as we think about building trust in public health and really helping support investment in public health as well.
Can I just second that? Because I think Susan's point here is probably one of the, maybe the most important of the afternoon, because I think at the end of the day, the currency that public health runs on is trust. And for too many Americans right now, they are equating public health to vaccine mandates or mask mandates or school closures. And they have no idea that public health is ensuring that our air and water are clean and everything Susan said, our roads are safe and our schools and businesses and restaurants are hygienic and we're keeping substances away from harmful substances away from our community, infectious diseases, all of that stuff. That public health is part of our nation's infrastructure, just like the electric grid and telecommunications and roads, bridges, and tunnels. And we have to think of it. So it's a kitchen table issue, right? We need to make public health a kitchen table issue and somewhat relatable. And I think we've heard that from both Secretary Sebelius and Secretary Leavitt. But ultimately, it's trust. And so we can talk about investments, we can talk about governance, we can talk about workforce, we can talk about data. Those are all challenges. But the core issue comes down to trust. And I think also building those multi-sector alliances with business, with faith-based communities, with community-based organizations, so critical for us to do the work that we know is important to do. So sorry, I know that wasn't the question, but I just felt
absolutely. It then puts you on the hook for this next question, Anand, which is getting to that point around trust. I mean, there are challenges to the issues of trust, public's trust, but also ensuring that the agencies, federal, state, and local, are able to do their job. You heard that in the overview of the presentation. And so a question here is, with these types of proposals that potentially could restructure agencies or put into question the authorities of agencies, what can we do in terms of our roles as advocates or others to ensure that those types of changes, structural changes and weakenings of authority does not happen, and elevate this as it could be a risk for public health?
Yeah, well, I mean, I think it's important to ensure that any solution matches the problem, right? So, for example, at the federal level, ideas of breaking up agencies because it might help us respond better to an emergency, those don't really always hold water, right? For example, this idea that we should de-link chronic diseases from communicable diseases. Both are inextricably linked. And the threats that we face today are both chronic as well as infectious diseases. And we need to have agencies at the local, state, and federal level that can respond to all of the threats that are there. So one is just, I think, making sure policymakers understand the myriad threats that we face. And then really just helping them understand the evidence base behind how we respond to all of these threats as well, that this isn't sort of big brother or isn't the nanny state. This is based on science, this is based on evidence. And then having allies in other sectors also carry the message as well. So I think that's probably the best way, whether it's threats at the local level, state legislators, or threats at the federal level in terms of Congress, making sure that they understand that the solutions sometimes that are putting forth aren't always going to address the problem that they see. Certainly there are things that we can do better. Let's not make things worse.
Absolutely. I think a key part of what both you and Susan are also articulating is talking about the impacts, right, of public health and how, it is truly making a difference in people's life every day. It's improving health. It's addressing and protecting from threats that we may not even know or be aware of. And some of these investments, when we speak about recent investments, for example, around data, and data was a big topic in our first panel with the secretaries, was the importance of modernizing the data systems. Fred, you're leading Parkland that has been actively engaged in this effort. And this is another bright spot that we can talk about when we say, when you invest in this, there is a return on the investment. And that is, for example, what's been done in electronic case reporting. Can you tell the story for us of what has happened at Parkland in terms of how you've really been able to advance this work, and it's actually helping to improve opportunity and lives, for the people that you're caring for, and the partnership with public health that you have in doing so?
Sure. Well, we have invested heavily in being able to, take the step from the moving to the electronic health record, as Kathleen talked about earlier, and then being able to now, how do you use that information and the myriad of other sources of information that's available out there to understand the health of the population, and to be able to point to where the needs are and how do you address those needs. So things like monitoring the areas of greatest need according to demographics and social needs and other chronic disease indicators, to be able to identify where to invest your education resources or your interventions or your next clinic. So to be able to do that. But then at the level of reporting, what you've mentioned, a number of health systems have now gone to electronic case reporting. So moving from either the paper or from the health record or from the lab reports, but to be able to do that electronically, report that to the CDC, get that information back to the states and the locals, to be able to track in more real time trends, whether it's respiratory viruses or whether it's chronic disease trends that you can intervene on. But it sounds pretty simple, but it involves investing in data systems. So you have a common language. Public health has a different language than the hospitals. And so being able to invest in those systems, the time, but then the return is, it's so much easier now when it's flowing from Epic into the federal and state reporting systems to be able to have reliable, consistent data. It's like I said, it sounds pretty simple, but there's a lot that has to go on behind the scenes to be able to make that transfer happen. And health systems have to invest in that, and public health systems have to be able to invest in that, and they need resources to be able to do that.
Why don't we turn to some audience questions, if we have any audience questions at the moment? We have a question from the virtual audience. Yes.
A member of our virtual audience asks, what are the best ways in which policymakers can support essential public health workers specifically who are instrumental to ensuring all systems continue during crisis, emergencies, and pandemics?
Brandon, could you repeat that question, please?
What are the best ways in which policymakers can support essential health workers specifically who are instrumental to ensuring all systems continue during crisis, emergencies, and pandemics?
Who'd like to take that question?
I'm happy to start off,
Yes.
and then folks feel free to chime in. I think this goes back to also behavioral health, mental health resources that are so important for the population. Certainly for our first responders, also critically important as well, whether that's public health workers on the first line or other public sector workers. So I think one is that. Second is showing our public health workforce that we value the work that they do. And really, at the end of the day, ensuring people understand their value goes back to what are we investing in our workforce? And investing in our critical public health workforce through recruitment efforts, through pipeline programs, through training, through making sure that they are making a salary that is market rate. Those are all things that are important. And I know, we coming out of the pandemic saw a 30% vacancy rate, close to 30% vacancy rate in our public health department from people retiring, people who, spent those several years working incredibly hard and then were ready to move on to something else. And for many that, suffered the impacts of mental health and post-traumatic stress and many other things. But the way that we were able to make an impact on that number and decrease it by 30% over a year was by supporting pipeline efforts. We had partnerships with our HBCUs to allow interns to come in. We were joking that we don't do tours, but actually we did do tours for elementary school students, high school students, graduate students. We started fellowship programs that enabled people to get their experience. We looked at all of our data and identified the types of workers that had the highest vacancy and turnover rate, and then we invested in salary efforts thanks to some funding we got to the legislature. So really, really intentional investment. Oh, and we created a workforce campaign, I think, talking about a lot of those ways that public health supports the community, both to educate people on what public health does, but really to also recruit the next generation of workers into public health. So I think all those investments are important when we talk about workforce.
Yeah, I'll just add that there's a very important CDC public health infrastructure grant that's playing out around the country right now, and many, many people are being employed because of that. But there's a concern what happens at the end of this grant to that public health workforce. And without the long-term sustainable investments in public health, it's going to be hard to maintain that workforce. As you all know, the best research indicates that we have about a $4.5 billion annual gap in ensuring that our public health departments have the capabilities they need to assure the conditions that populations can be healthy. It's unclear whether we're going to get that long-term sustainable investment from the federal sector. And so I think thinking about, as Secretary Levitt said, what are other ways to shore that up? Certainly some states have moved forward. Judy Monroe's here in the first row. States like Indiana have pushed forward their state legislature to increase investments in public health. There are probably red, blue, and purple examples like that, but we need to understand how we're going to get this long-term sustainable investment. But it's probably going to have to come from the federal, state, local, as well as the private sector as well. So the funding is connected in some ways to the workforce and something that we need to continually think about.
Absolutely. Do we have some more audience questions?
Well, thank you. Octavio Martinez, Executive Director of the Hogg Foundation for Mental Health, as well as a TFAH board member. Great panels. Question, you mentioned collaborations, mentioned different sectors. One of them I haven't heard too much about, and I'd like you to weigh in on, is actually the private sector. So having a healthier America is extremely important to all our employers, large corporations as well as small businesses. How can they, looking forward, do need to participate? How do we bring them into the fold to be part of the solution that is not just on just the shoulders of the public health infrastructure and even our healthcare system, but we need them at the table. And I'm just wondering, what thoughts have you had on that?
Any of you?
I can start real quick, and then while Fred is well, Fred and Susan think about it. So we did some work, Octavia, with the de Beaumont Foundation a number of years ago, and we call it Good Business, Good Health. The idea was that every local public health officer ought to be connected with their local chamber of commerce, and there ought to be connections in every community in this country between local public health and local business, and this idea that the two are absolutely connected, and whether it's what's good for business or bringing more people into a community, a healthier community is good for business, and it's good for, and it's good for health overall. And so I think the broader theme here is public health connecting to the private sector and other partners that are absolutely critical to improving health. And I mean, I think that's a theme today that we're hearing as well. So that's just one example, but I'm sure they have more ideas and thoughts.
Yeah, I'll just build on that and agree with everything Anand said. And I think, I think about specific examples that we've seen in public health. A lot of the opportunity for investment, particularly in prevention, has only been with the partnership of our private partners. I think about public-private partnerships like we've been able to do around supporting social resource needs and connecting people to different needs in our community. And I think about, at the end of the day, for many of our rural communities especially, it goes back to exactly what you said, which is that the health of the entire community and of the economy of that community really depends back on the health of that community. Particularly I think about the overdose epidemic and where we saw many, many sectors of many partnerships with our businesses across North Carolina, helping to think about how we combat opioid overdose, whether that was providing support services in their community or whether that was providing jobs to people who were in recovery. And so I think absolutely agree, part of the role of public health is to be that convener, and working with our private sector partners is a critical part of that job.
I'll just highlight another effort, and we saw this emerge through the COVID-19 pandemic, was the establishment of this Health Action Alliance. Some of you may be familiar with this, which is bringing business leaders with public health to really address creating healthier communities, a healthier nation, and understanding that their workers having healthy employees is really critical for employers. This alliance we actually have worked with, for example, with regards to COVID-19 vaccine messaging, really educating around the importance of the role that employers can play in actually helping to promote health. And one of the recent initiatives of this alliance has actually been now the establishment of a national commission on climate and workforce health, recognizing that we're dealing with more and more climate threats as well, like extreme heat. And extreme heat is really a detriment and danger for workers. And so understanding how to bring public health and the business community together, CDC Foundation, de Beaumont Foundation, and others are really supporting this effort. So I think to your point, Octavia, it really is critically important to bring these other sectors together to recognize that we all have a role to play in advancing the public's health. I am seeing that we are at time. I know I am getting the no, you may not continue. As you can see, these are really important issues that we are facing, certainly in public health. Join me, please, in thanking our second panel for this conversation. Thank you all. And please feel free to have return to your seats. As you can see, there are numerous issues that we grapple with in public health and could have this conversation all day and appreciate the engagement from our audience. I am now going to introduce our closing speaker, Dr. Eduardo Sanchez, who is going to provide some closing reflections and remarks based on the panel discussions that we've had. Dr. Sanchez is the Chief Medical Officer for Prevention at the American Heart Association. The American Heart Association is one of the organizations that has endorsed the Blueprint Report, as you saw. And in addition to the clinical and prevention expertise that Dr. Sanchez brings from the American Heart Association, he also brings the frontline public health experience at the state and local levels, having previously served as Texas Commissioner for Health, Texas State Health Officer, and local public health officer for Austin, Travis County. We're also proud that Dr. Sanchez is a member of TFAH's Board of Directors. Please join me in welcoming Dr. Sanchez to the podium.
I think we have a public health PSA theme. Public health is there. I think we heard that loud and clear. Thank you, Dr. Gonzaga, for that. That's the theme. Public health is there. Thank you to our panelists. Thank you to all of you who attended. Thank you to the awesome staff at TFAH and at the National Press Club for making this event possible. As you heard, the time to advance the nation's health could not be more critical. There are things happening right now that are going to put the public's health at risk. And a stronger public health system would enable us, would make it possible for us to protect the health of so many people. This report provides a roadmap for the incoming administration and Congress to do the things that need to be done for us to have a stronger, more resilient, more responsive public health system. We heard from panelists who have perspectives that are critically important. Critically important. One, we heard that, again, public health is there. There's an opportunity to reintroduce the public to what public health is. That every single day, from the moment you wake up, every single thing you do, from washing your hands to turning out the lights and your house not burning down, are in some form or fashion public health. We heard about public health having so many roles that we need to and have the opportunity to remind folks about: convener, collaborator, connector, connectors with health systems and the private sector in our communities, as planner, as leader, as coordinator, as problem solver, as responders. All of those are apt descriptions of public health. We heard trust being the centerpiece of the work that we do, and something we have to wrestle back from the public who, for the wrong reasons, has put less trust in us. And yet every single day, every single minute, public health is there. We heard loudly and strongly that we need a stronger data system for public health and public health plus, because the public health plus is what connects the other pieces, whether it's environmental data from EPA or what's going on in hospitals, consumer data from pharmacies. We need the data systems. We need the data scientists who can help us understand what it all means as we try to merge that. And then I think I heard loud and clear that there's opportunity for us to, A, describe what we did, characterize it in an objective way, but also learn from what we did, apply those learnings in the way all of us have learned about continuous quality improvement to say, we did better today than we did yesterday. We're going to do better tomorrow than we did today because we learn as we go along. So we have a solution, a blueprint in front of us. We have speakers in this report, which I believe lay out a clear rationale for Congress to seriously consider. We have a job to do to put this report in as many hands as we possibly can. We have a responsibility to understand that the public health workforce that we have talked about needs our voice to give them the resources they need and the ability to get the job done. We have to equip public health and ourselves with tools to counteract the misinformation and disinformation that threaten the health of our communities. So I want to finish by asking each of you to take the TFAH's Blueprint report, not just to heart, but to any place where it might be looked at and make a difference. Share it inside your organizations, share it with those that you collaborate and connect with, make the case about a strong public health system. I thank all of y'all for being here, and I thank those of you who are in the trenches doing the work. Thank you for what you do every single day to make a difference in people's lives. So on behalf of TFAH, we are done. Thank you. I lied.
Thank you, Dr. Sanchez. Appreciate your closing reflections and remarks. We are near done. Yes, we're just going to acknowledge and say thank you to all of you. Thank you for being here. Thank you for your support. This is, yes, TFAH's blueprint for the next administration and Congress, but we didn't get here alone. As you heard Dr. Everett express, we had so much support from partners across the country, and so we thank you. We thank all the individuals who are here in this room and those of you that are watching online, to all of our speakers for your engagement and your insights, to our event management team who has helped us throughout this event today, PSA, to AI Media Captioning Service who provided the live captioning service, and Vital Signs who has been providing the on-site sign language interpretation. I also want to acknowledge and thank, you've heard a couple of them asking questions or speaking to you, our board of directors, and ask our members of our board of directors who are in attendance to please stand and appreciate them for their support and service to TFAH. And then most importantly, and I ask them to also stand or wave if they're already standing, are the staff and interns of TFAH who have been working tirelessly, doing amazing work on this blueprint report and this event. So thank you very much. The work is truly just beginning of what we need to do in these next 4 years to continue to promote and protect the public's health. I thank you all for being here. For those of you in the virtual audience, we are now at the end. And for those of you who are here in person, we invite you to join us for a reception next door. Thank you, everyone.